Hi, I'm Dr. Herbert Loong from the Chinese University of Hong Kong, and I'm here in Chicago at ASCO 2026, where there have been some very exciting data being presented for HER2-mutated non-small cell lung cancer. I presented the poster on SOHO-01, which is a phase 1/2 clinical trial of a drug known as sevabertinib in patients with HER2-mutated non-small cell lung cancer. During this presentation, we updated two cohorts, which is cohort D and cohort F, included patients who have had prior treatment but no anti-HER2 directed therapy, as well as patients who are treatment naive. In both cohorts, we saw promising activity of sevabertinib, and certainly, specifically in patients with tyrosine kinase domain or TKD mutations, we're seeing response rates north of 75%, as well as a very good duration of response. One of the major concerns about sevabertinib previously has been diarrhea being a side effect. And what we've seen is with good diarrheal control, as well as specifically in patients who've never had prior treatment in cohort F, the chance of having grade 3 diarrhea is less than 5%, and it's actually very manageable. So overall, I think we've seen a further improvement in terms of treatment outcomes for patients with HER2-directed therapy. Sevabertinib has shown its efficacy, and there are certainly other compounds that's being discussed at this year's conference. And I think this is a good beginning for targeted therapies for HER2-mutated non-small cell lung cancer. Thank you.
Thank you, Dr. Loong, for your presentation on the SOHO-1 data. I am Dr. Isabel Preeshagul. I'm a thoracic medical oncologist at Memorial Sloan Kettering Cancer Center, and I'm here to talk to you about what's new in the HER2 space for patients with metastatic non-small cell lung cancer harboring HER2 mutations. What struck me about this ASCO meeting was the patient-reported outcomes from the 𝗵𝗵𝐺-Lung1 study, which was a phase 1 study looking at patients with metastatic non-small cell lung cancer harboring HER2 mutations that were treated with frontline Zongertinib, which is an oral tyrosine kinase inhibitor. So what struck me about this data was not only that there was a 71% response rate in the frontline setting, but also that there was 33% intracranial activity, which is very important to me because we know patients that harbor these alterations tend to have a high burden of CNS disease or high risk to develop CNS disease, and this is a sanctuary site that we always want to keep our eyes on. So while we do have 2 FDA-approved agents for patients in this space, whether that be chemotherapy and immunotherapy or frontline Zongertinib, which is now FDA-approved, someone that I might think about Zongertinib for would perhaps be someone with high-burden CNS disease that I'm worried about or CNS disease that I'm not able to offer radiotherapy for. So now we are pivoting to the early stage setting where, much like you know, in the EGFR and ALK space with ADAURA and ALINA respectively, Zongertinib is now moving into that setting with a study known as the 𝗵𝗵𝐺-Lung3 study, which is a large phase 3 study that is actively accruing, looking at patients with resectable stage 1B to stage 3 that either received neoadjuvant therapy or adjuvant therapy following surgery. After that, they are then randomized to either receive Zongertinib or standard of care physician's choice. And I'm really excited about what these potential outcomes could be. And what this study is emphasizing is the importance of doing next generation sequencing testing on all of your patients regardless of stage. You are missing out on opportunities, and you are missing out on good potential outcomes. And the final abstract I'm going to talk to you about today was a survey that was conducted at 2 large academic centers around the fall of 2025, looking at HER2 testing utilization and what were the inefficiencies and barriers to obtaining HER2 testing. And actually on a chart audit, what this study found was that HER2 testing was only ordered 51% of the time. And some of the reasons for that may be just because limited access to testing facilities, communication barriers between oncology and pathology, lack of reflex testing. So what this study showed is that this is a real opportunity to lean in here and make HER2 testing part of the workflow from the start.